Thank you all so very much. It is always great to come and speak to yins and join yins and fellowship. I look forward to this every year. It's something I really enjoy, and then the added bonus is it's back here in Chattanooga, and so I have a lot of fond memories from my residency. I really enjoyed my residency, and so share with you a really quick story. Last night, I was hungry. I got here about midnight, and I was hungry. And the only place that was open that wasn't it was a place I would go to. I don't go to bars, and so I went to this little city cafe diner down the street here, and I used to go there after my 24-hour calls, which usually turned into 36 hours roughly. And one, I think it was a Sunday morning, I was particularly tired and had a really vigorous night and really worked hard that night. Well, I fell asleep at the table. And they all knew me because I've got my doctor get up on without the coat, but I had my scrubs on, stuff like that, and I fell asleep. And they were nice enough to let me sleep for about an hour. It was really nice of them. They just kind of like pushed me over to the corner, and someone my size, it took 3 or 4 of them, and so so I slept for about an hour on one of their tables. And then they were like, "Sarah, you can't stay here, but you don't have to go home, but you can't stay here." And I was like, "Oh, okay, sorry, thank you." All righty. So today we're going to talk about emerging trends of fungal infections. This comes at a very poignant time, actually. About yesterday or 2 days ago, the Tennessee Health Department sent out a advisory to as many physicians are signed up to their email list, and it was about Candida auris. So that is going to be the primary fungal infection that we talk about today, to give you an update on that, what to look for, things of that nature. We're also going to go over many other fungal infections that you might come into contact with or that may present to your office with kind of a quandary, and you're wondering, could this be fungal? And if it is, well, what kind of category will it fit in, and things like that. So I have no disclosures. I don't own anything. All I have is debt, so there, you know. So here's what we're going to do today. So the first fungal infection can be attributed to Hippocrates. He, in 400 BC, he noticed that the white spots on the backs of people's throat look like the spots on this little bird called a thrush. And we have these in Tennessee. This is the ones we have in Tennessee. They have black spots, but in Greece, they have white spots. So that's how the term thrush came about, and that was the first fungal infection. So that's usually a yeast infection, or Candida albicans is most likely what it was back then. And these are the different albican species that we have. As you all know, my eyes are terrible, so I'm going to kind of move around until I figure out where I can see this very well. Okay. Oh, this is better. Okay, so these are the different Candidas that we have, and these are the yeast forms. So funguses are split up into 3 groups: yeast, molds, and then dimorphic fungi in the middle. They slide in between, depending upon the environment that they're in. If it's a dry, desiccated environment, they're going to tend towards the fungal side. They'll become spores. If it's a wet, temperate climate like here in Tennessee, they're going to be more in the mold phase, where they're growing in different places and things. They're actually vegetative. So Candida albicans, that is going to be 51% of isolates that are obtained in the United States is going to be Candida albicans. That changed this year. Now that's 49%. 51% is the rest of these combined, okay? So then you've got Glabrata cruzii. These are particularly a nuisance because they are inherently resistant to fluconazole. So this is your patient that comes in with some sort of yeast infection, whether it be oral or vaginal, or in diabetic men, balanitis, in their inguinal canal, under fat folds, things like that, that will not get better with nystatin and fluconazole and those two major ones we use, okay? You have to go to a different antifungal to get these, and so that's why they become very bothersome. Paropsilosis and tropicalis, these are exquisitely sensitive to fluconazole, so they respond very well. Lusitaniae, fortunately, is rare, but it is inherently resistant to almost every, it's inherently resistant to amphotericin B. So someone who's critically ill with this, you're going to be giving them, well, the ID specialist may be giving them amphotericin B, and it may not work. Think of this one. And then at the very bottom is our little friend, Cryptococcus neoformans. So Cryptococcus, we think of in HIV patients that causes meningitis, but it can infect immunocompetent patients, and this is more of a pulmonary infection or skin infection. You detect it through blood rather than cerebral spinal fluid, and as many people are on biologic agents from their rheumatologists now, this is becoming more of a problem from time to time. Still very treatable, but it's something to think about in people who are on biologic agents that come in with chronic headaches. It's something to think about, okay? Now, here we have our molds. Aspergillus, especially the second one, Aspergillus nigrans, that's going to be your black mold that's found in houses that's had some sort of water leak, whether it be from the roof or the pipes, or kids getting in and splashing in the bathtub way too much, and it tends to puddle and things like that. Well, that creates a place for aspergillus to grow. Mucormorales, that's mucormycosis. This is the one that gets into the nasal cavity and the sinuses of people who have uncontrolled diabetes, and can erode up into their eye, or can erode through the bone up into their brain. And this is, that's definitely a problem. Fusarium. You don't see that very often. Fusarium was included because that was the causative agent for the fungal meningitis outbreak from the compounding pharmacy in 2012. And then Scedosporium, that's your spaghetti and meatballs. Whenever you look at it under a microscope, it's got these big, huge meatball-looking things that are the spores, and then the hyphae look like the noodles, okay? And then, and then the last one, which is not too important. Okay, then we get to our dimorphic fungi. And like I said, this one switches back and forth depending upon the environment that it's in. So that's your histo, your blasto, your coccidiomycosis. So who here is from the southwestern United States? We got one. Okay, so that's important to the one person. But valley fever, or Santa Anna's revenge, coccidiomycosis, this infection here, because it's a dry, arid, desert-like environment, the spores form. The Santa Ana winds carry them all the way across Southern California, Arizona, New Mexico, into western Texas. So if you've got patients that winter in Arizona for their arthritis, like I do, they may come back with this. That happened to me. Yeah. Okay, now, histo and blasto, those are the ones that we deal with here. So histoplasmosis is Western Tennessee and Middle Tennessee. Blastomycosis is Eastern Tennessee and Middle Tennessee. And right around Nashville area, the middle of Middle Tennessee, they slam together. And so, and then there's a wide swath there that encompasses us. So I get patients with blasto and histo infections. So I'm always on the lookout for both of them. Histoplasmosis, the history is going to be a patient that's cleaning out an old dusty barn or an old dusty house that has barn swallows in it, or the roof isn't that great and birds have flown in and they've pooped all over the place. They're in there, they're scrubbing, and they're aerosolizing all this, and it goes right into their lungs. Histoplasma can be self-limiting whenever in an immunocompetent person. An immunocompromised person, and once again, like we talked about, there's many more of those now based on some of the medications that we give that are given to them, okay? These, you're going to see this more often, and it can become invasive. And invasive histoplasmosis, that is rough, okay? It gets into their GI tract, their liver, their spleen. It can get up into the brain, cause an abscess. And itraconazole is what you treat it with, but it can be pretty rough. Okay. Blastomycosis, though, is carried by bats and guano. And the only reason why I know that is those Jim Carrey movies from the 90s, okay? So, most of Tennessee is caves, right? We have some really, really amazing geographic formations. And just north of here, there's this music venue called the Caverns. Have any of y'all been there to see a music performance? I went a couple times. It is awesome. It's kind of like the Red Rocks. The acoustics in this cavern are really interesting. Well, while I'm down there, I'm looking up, and there's a bunch of bats hanging out, listening to the music too, because they enjoy it. And I'm like, well, then there's that. So blastomycosis, this is usually a cutaneous problem. Now, it can get into the lungs. It can become disseminated in immunocompromised patients. But cutaneous blastomycosis are these thick, black lesions where someone has an imperfection of their skin. So I've seen it superimposed on psoriasis. I've seen it on men's faces where the person shaved that day, microscopic nicks to their skin, and then they've got these black spots all over their face, and everyone's looking at them like they're a leper. And it's like, well, not quite leprosy, but we're going to get, it's like we could get there one of these days. So blastomycosis, we're going to see a picture of some of these black lesions in a little bit, but they are quite interesting. Okay, and then, okay, yeah, penicillium. They've renamed penicillium this T word. Why? I don't know. Okay, this is the coolest gram stain of all of them. It looks like a paintbrush. Some of you may remember that. And at the end of the paintbrush are these little round spheres. That's the spores coming off the end of the hyphae. And so they literally look like a paintbrush, but not like Da Vinci's paintbrush. It's more like Joe the painter's paintbrush. It's really quite interesting. Okay. And then sporotrichosis or sporotrix. Okay. That's rose gardener's disease. Had a case of this whenever I was in med school. It was a gentleman who had went to New Orleans to help with the cleanup with his church group, and he had a huge necrotic black-gray lesion on his middle finger that drained some of the oddest looking black drainage you've ever seen. And no one had a clue what it was. So I had plenty of time. So I just went down and sit and talked with the guy for a while. And he wound up telling me that he went to New Orleans to help with this, and this happened about shortly afterwards. And I was like, oh, what part of New Orleans did you clean up? He goes, well, they had us in the wealthy section. We didn't go to the lower Ninth Ward, the poor section. We were in the mid city, and we tore out a bunch of rose bushes from around these houses because they was all dead, and the owner wanted them gone and stuff like that. And I was like, oh, did you get poked? He's like, yeah, they didn't have gloves for us, so I got poked all over the place. And I was like, uh-huh. And you think about this, New Orleans is a temperate, wet climate, but it was really wet then. So he had the vegetative state in his middle finger. And we got the surgeons in there, debrieded and stuff like that. He kept his finger. So, and then paracoccidioides, sometimes coccidiomycosis is mistaken for this one. They're treated the same, so not that big of a deal. Okay. So, in 2018, there was 607,000 hospital stays. I'm sorry, outpatient medical visits that cost $6.6 billion to Medicare. Now that's just Medicare. So fungal infections can be pricey whenever they have to be treated. And your three most common is going to be Candida, Aspergillus, then Pneumocystis jirovecii. This is this was PCP pneumonia, but then they had to rename it because why? I don't know. Okay, but this is the one that was in the 1980s became such a big problem when the HIV epidemic hit. Okay, now we'll see it in immunocompromised patients, and once again, there's many of them walking around with us every day. Okay. All right. Now, why is everyone freaking out about this Candida auris? Okay, if COVID taught us anything, public health officials love numbers, and they like trends of numbers. So as you can see, year on year, it's doubled a couple times, right? And it slowed down a little bit, then it doubled again, and now we went from just 100 and something a little over 100 cases in 2013 to almost over 2,500 cases in 2022. So it's had a steep curve. Okay, and currently there's been 8 cases in Tennessee. I had one of them, and spent a lot of time with those CDC health officials, and they are so enjoyable. And now here's the graphic representation of that data. You can see the light blue is your screening cases, and then the dark blue is your clinical cases. So you can see quite a large increase over time, and the curve is very steep. So here's our current map. You can see we're in kind of the lower risk category, but we're not free of it, unfortunately. It first appeared in New York, which a lot of things first appear in New York, which is interesting. Well, there's so many travelers to New York City. That's one of the reasons why. But then California, and Nevada, Texas, Florida, Illinois, your big travel destinations for the United States, that's where it's mainly at. Then it's spilled over into other places. Our patient my patient that had Candida auris, it was actually a vaginal swab, bless her heart, and she just could not get rid of this, could not. And when it came back from the state lab, I looked at it and I was like, well, this has got to be a typo. They meant to put albicans, they put Oris. Whoops. So I give her the treatment. She cleared up fine. So it was really good. Okay. So an invasive pulmonary infection, you're going to have fever, cough. And this is one of those really, really difficult coughs that they come to the office and they say, Doc, I've been coughing for 3 months. What's wrong with me? And you're just like, ugh, I've only got 10 minutes to figure this out, you know? Okay, so this is one of those, I've got a cough and I need to know what it is type situation. The shortness of breath. The fevers, they'll happen in the evening dusk hours. And they're pretty high too, like 102, 103. They sweat like you wouldn't believe, drench the bed sheets. They got to shower, change their bed sheets, change their pajamas. Okay, then, let's see here. Oh yeah, now fungemia. Whew. Fungal infections, when they get into the bloodstream, usually it's some sort of foreign body that's allowing them to get where they're going, whether it be from a central line, a PICC line, one of those LVADs that sits beside them on their, like Dick Cheney had. It sits on his, well, it did. It sat on his nightstand, and he didn't have a pulse, so he was the Walking Dead. Okay, so, but it's essentially a heart in a box sitting beside him, and thank goodness it was plugged in. Okay, and so, let's see here. Then the chronic fatigue, the acute confusion. Oh yeah, then the cutaneous, we talked about the cutaneous fungal infections, what they would look like and things of that nature. Okay, so some cool stuff now. So here is cutaneous blastomycosis, and these, they're mounded, have the black center, scaling. They've got the red base indicating the acute inflammation. And then this gentleman has this on his ear. I see that a lot on ears, which is interesting. And then this is on this gentleman's nose. Okay, so whenever I'm working up a patient, the laboratories that I obtain, this is what I'll get. Okay, now I don't do every test on every patient. That's specifically what I'm going to do. But you've got your urine, blasto, and histo antigens. You've got your aspergillus antigen, which is serum. You've got your beta-D glucan. That's a piece of the fungal cell wall. It doesn't tell you what fungus you're dealing with, but it'll give you a ballpark idea if they've got fungus in their body or not. And a cutaneous fungal infection will not have a positive beta-D glucan. Okay? That's also called Fungitel. You may have seen a Fungitel ordered or something like that. Okay, the Cryptococcus antigen you can get in the cerebral spinal fluid, or you can get it on serum. And then you've got your different cultures, and you can get a smear, a stain, or a culture. I encourage you to get a stain rather than a smear. A smear is very, very fast. You'll have it within an hour. A stain, they had to go through a lot more intricate detail and trying to help you out. So I encourage you to wait that day on a stain rather than getting a smear. Okay? So this is Candida auris. That's the first one's the gram stain. The second one is what it looks like on microbiology. And I would be remiss without doing a little bit of micro. So let's study the gram stain just for a little bit and tell me how you know this is a fungus rather than a gram-positive cocci. or a gram-positive coccobacillus. What you think? Not uniform. That's a very good observation. So, kind of like one of those magic eye things from the 90s. I sit and stared at this for an hour, then realized my computer was off. And so, um, and let's see here. I need to get just a little closer. Let's see here. Where did he go? Where did he go? Where did he go? You were here the other day. Ah, bud. There you go. That's a budding yeast. That's how you know it's a Canada. All right. And they're on there, I promise. I just can't see them. Now, the microbiology is a pale yellow, creamy colony that is on the streak in fungal plating, because if you think about it, if they don't do it under a hood, you've got all these fungal spores floating in the air. They take the plate off, they work on it, something falls out of the air, they plop it back down on the upside down, they set it in the incubator. And then there's a colony that shows up. They're like, oh, we've got a colony. And you go down there, and it's not even on the streak. And it's like there's no way it could possibly been inoculated onto this plate. Now, the microbiologist and the microtext, they know this, so you don't have to worry about that. But these creamy yellow round colonies. Okay. Now, imaging-wise. On your chest x-rays, you're going to see bilateral infiltrates. Sometimes you'll see an effusion, sometimes you won't. On CAT scans, you've got a couple little signs, and I always like the history of these. These are interesting. So you'll have bilateral infiltrates. A lot of times you'll have an effusion, but, you know, COVID, bilateral infiltrates, interstitial infiltrates, like great. Now I got another thing to worry about. Okay, but the histories don't match at all. Okay. Then your air crescent, you've got your cavitary lesions, multiple nodules, and these all indicate various things. Okay, and then in MRI, you can have a ring-enhancing lesion indicating an abscess. So there's your chest x-ray. This could be Candida pneumonia. When I was in training, they told us if you diagnose a Candida pneumonia more than twice a year, you're overdiagnosing it. Now that's a little silly, but but it did get across the point to me that if you're going to do that, be really, really, really sure that you've ruled out everything else, and that you're thinking, okay, this is probably a Candida pneumonia. Okay, so you can see the infiltrates down here. This one does not have a effusion, thank goodness. But here, you've got big, dense, compressed lungs, air bronchograms, and it's probably hard for y'all to see, but the lung ends right here, and this is a big old effusion sitting right there. Okay. Now here is our air crescent with aspergillus, and it has a little cup look to it. Not the cup look of a pulmonary embolism, but it has the crescent shape right there. Then here you have a bunch of nodules all over the place, and this is in a Candida pneumonia or a yeast pneumonia. And so all kinds of little nodules everywhere. And then your cavitary lesion with aspergillus. Aspergillus in the lungs, it's pretty rough. It will just start eating away at their lungs. And a lot of times it can be 3, 6 months before they'll present, because they'll just have this chronic nagging cough, and they've got lives and work and other things they got to do, and they got to get their Humira shot in every 2 weeks, and so here we go. And now here's mucormycosis. As you can see right here, it is eroded into the orbit. It is on its way right up through there into the brain. And once again, the highest risk individuals for this are your uncontrolled diabetic, people with diabetes, type 1 or type 2. And let's see here. What else is important about mucor? The last one I had of these, his nasal septum was so huge, it closed off both of his nostrils. And he couldn't breathe out of his nose. And that's why he came to the office. And I was like, And he said, I've got splitting headaches. And I was like, oh, no. And it had eroded through his cranium into his brain. Well, come on now. There we go. It had eroded on him, so we had to treat him with some really heavy-duty stuff, but he got better. Okay. And then on MRI, you've got your ring-enhancing lesion. Okay. So how are you going to treat these folks? And this is interesting. Okay, if you've got a really, really, really sick patient and you're puzzled, you're like, I'm not sure what kind of fungus this is, go with your echinocandins first. There's caspofungin, mycofungin. They're about equal. Caspofungin's the oldest. We've studied it the most. All of the inferiority studies were done against caspofungin. But a lot of times on formulary, you'll have mycofungin. That's okay. There's not a problem with that. There's a third one called anadulafungin, and I don't know who thinks of these names, but it didn't really survive marketing and things like that. I can't say that I've seen it used in the past 10 years. I was at one hospital that had it on formulary, and we would use it, and it was always fun to try to spell that. Amphotericin, and as y'all remember, the nickname of it was amphoterrible. Okay. Why is it amphoterrible? It will burn up a set of kidneys. I mean, it will take them out of this world. Well, when you start messing with the kidneys, what else do you get? Electrolyte imbalances. So you've got to watch their potassium, magnesium, and phosphorus like a hawk. Their phosphorus will shoot up, their magnesium will plummet, their potassium will plummet, and they'll start having arrhythmias, and everybody's running around with their hair on fire trying to figure out why their potassium dropped out of the bucket. They're like, did we give them beta-2 agonists? Did we give them a bunch of insulin? What have we done? And it's actually this, and it's my fault. Oh, great. Okay. So you've got 3 different types. You've got your traditional amphotericin, rarely ever used. You've got your liposomal, called amazone, liposomal complex, and then your lipid complex, called Abelset. Okay, doesn't matter which one you use. The amazone will get into the brain. The Abelset, which is the lipid complex, it will definitely get into the brain because of the lipid complex. Okay, it'll get into cerebral spinal fluid. It has very good blood concentrations, things like that. Ambazone is usually what's on formulary. Every once in a while you'll come across Abelset. There may be a few exceptions, but I think those are just my board exam questions. Okay. And then your triazoles. And these are the ones we're most familiar with. Fluconazole, voriconazole, itraconazole. And then there's this posaconazole, What's famous about well, not famous, but really proud of posaconazole? It was developed in Memphis, Tennessee, and it was thought to be the end-all be-all treatment for histoplasmosis. And how many of y'all did spend time in Memphis during your training? Okay, I guess I'm the only idiot that did that. Okay. 2 hours in town, car's gone. 2 hours. It hadn't even been unpacked yet. All they got was my dirty underwear and the car, but that's, it was a piece of junk anyways. Okay. Posaconazole was made by Plow. It used to be called Sharon Plow. The Sharon family got out of the business, and it became just Plow. And Plow, they developed this in Memphis to try to treat histoplasmosis. If you all remember, Elvis died in the big Baptist Memorial Hospital, right? Okay. And what was really funny about it is whenever it got older and it fell into disrepair, and Baptist organization said, we don't want it anymore, we'll just give it to the state. The med school can have it. Okay, that was cool, but it unfortunately was decrepit. Well, when it fell into disrepair, it used to say BMH on the top, Baptist Memorial Hospital. Well, the H fell down, so it was the big BM. Well, they imploded that thing, okay? And it was kind of like a Las Vegas casino implosion, like the mayor showed up and all the elected officials, and I think the governor was there. And they, 3, 2, 1, shing, boom, okay. And that sucker come down. Well, this huge plume of dust went floating its way eastward through Midtown, through East Memphis, into Germantown, and Cordova, and all those ritzy, wealthy people's areas. And guess what every one of them got? Every one of them got histo. Because they unsettled that earth and all the bird poop. They unsettled all that when they imploded that building. And posaconazole went to just the production went to outer space, and it treated pretty much all of them. Itraconazole was cheaper, so they used that some. But that's the story of posaconazole, and that's why you never hear about it again, because no one's dumb enough to do that again, hopefully. Okay. Then there's the isvuconazole. It goes by the brand name Cresemba. It was specifically made for mucormycosis, and that's all you need to know about it. Okay. So let's jump into our antifungal review now. In bacteria, a couple years ago, here at the Reed House, I did a antibiotic review, and that was a lot of fun for me because I could talk in generals, and it was very easy. It was compact, that was very easy. Can't do that now. Okay. So, yeast infections, these are all the fluconazole sensitive yeast infections, okay? And then Cryptococcus down here is a little slightly different, but this category over here is all your fluconazole sensitive. So your albicans, your tropicalis, your peropsilosis. Now, when someone has Cryptococcus in their cerebrospinal fluid, you do an induction of amphotericin B, then you do high-dose consolidation fluconazole, and then standard dose maintenance, and it's a year. Do we have time for one more story? Yins will love this one. I'll bring down the house. Okay. So, as a lot of yins know me, I'm single. I'm a perpetual bachelor. I think they make nursing homes, especially for me. Okay, so I was in the end of my first year of my um, fellowship down in Memphis, and we had a little gentleman there in town. He had he had HIV/AIDS. His CD4 count was probably negative something, but it was always in single digits. He didn't take his medicines because it was a government conspiracy. Okay, he was 70 something pounds, emaciated, um, and he had cryptococcal meningitis. He lived on amphotericin, essentially. I would admit him every 2 weeks. They just got, they didn't even work him up in the ER. They just would call me. I was like, great, yeah, okay. So after, a full year of admitting him every two weeks, we got a rapport. He'd ask me, how was the game the other night? Oh, it was great. How was the concert? Oh, you enjoyed it? Yeah. They took your wheelchair in? Oh, good, very good. I saw you down there. Hey, how you doing? Okay. So I go in this time, and there's this beautiful young lady sitting there. And there he is in the bed, all 78 pounds of him soaking wet. And he goes, Dr. Todd, you got to tune me up. I'm going on my honeymoon. And I said, what? So did my thing, was professional. Went outside, had a meltdown. Because at the time, I was about 100 pounds lighter. Okay, I was about 100 pounds lighter. I didn't have visible gray. I had all my hair. Okay, had relatively good earning potential. None at the time. Okay, so I was like, I could be a catch. Why am I still single and he has a fiance? Are you kidding me? And I was like, oh my goodness. Well, I learned that this was one of those generational poverty things, and we won't get into that part. But it was one of those moments where I really, really questioned what I'd done in life, and I was like, seriously, what have I done wrong? Okay. Okay. Now over here, we have our yeast infections that are resistant to fluconazole. So that's your glabrata, your cruzii, the Lusitania, and your Candida auris. Candida auris, you want to use echinocandins. There are some resistance patterns that's in the literature, but they are still the number one recommended drug. Okay. Now, molds. Okay. So, as you can see with mold infections, voriconazole is your lead bet. Okay. Then you get invuconazole, posaconazole. Rarely ever do I have to go past voriconazole. It's mainly like a tolerance issue for the patient. You can do serum levels to make sure they're not toxic, and that's what's causing, say, nausea, vomiting, diarrhea, something of that nature. But voriconazole is your major one that you use for those, okay? And then you've got your mold infections over here, and these are the ones that you're going to be using. So like Mucor, we had to start with amphotericin for him. Then we used the isvuconazole for his mucormycosis. Then these, they're not really too exciting, mainly voriconazole. Okay. And let's see here. Nope. Need to go back. Okay. So then your blasto and your histo. Itraconazole is going to be your first choice when they're really, really sick in the hospital and they're heading out of this world, amphotericin. And then there sits our little friend, posaconazole. Okay. Then Ah, yes, Coxy. Coxy, fluconazole works best for it. Who knew? Okay. And then your, let's see here. That's your dimorphic fungi still. Paracoccidioides, itraconazole works good for it. Sporotrichosis. Yeah, we used that, and it worked quite well. Now, this graph right here, this little figure right here, it tells you several things. So, amphotericin was made way back in the 50s, but still we use it. Then you had flucytosine. That, it's a buddy medicine. It's an adjunct therapy. You wouldn't use it primary, okay? But flucytosine has its own set of problems. But as you can see, since the mid teens, since the early 2000 teens, we haven't had a new antifungal come on the market, and the newest one is that Cresemba, that imvuconazole business. Your caspofungins, your echinocandins, the red ones, they were all developed in the early 2000s, and then fluconazole's back here as well. Okay, so development and R&D for this in the pharmaceutical industry, not that robust. And fluconazole resistance in albicans, 99% of isolates are going to be Candida albicans is going to be sensitive to fluconazole. So you're good there. That 1% is always the one that shows up, right? Okay. And that's when you have to kind of think outside the box, and you would use your echinocandins then. Now, the echinocandins, what's the big hang up on those? They're all IV only. Okay, so they have to either go to the hospital every day, get their mycofungin infusion, or you set them up at home with an IV line, and then you're putting a foreign body into a place where there's a bunch of fungus growing. You're like, well, isn't this one of those things that said it's going to grow on a foreign body? Yeah. Okay. Okay. So the mortality rate of Candida auris, 30 to 60%. When you get the treatment going and you remove whatever catheter or a foreign body it is, their mortality rate drops dramatically. So they can survive this, okay? The big thing is trying to control it and not let it spread. So hand hygiene, contact isolation, this is going to be your same for like C. diff. Terminal and daily cleaning of the room. There's special antifungal cleaners that the EPA has, or cleaning products that the EPA has designated. If you got that email, there's a list that's attached to that email that the state sent out last week. And so I did my due diligence and forwarded it to the head of the housekeeping, who just loves getting emails from me. Because that poor man. Okay, if you can use disposable equipment and things like that, so a thermometer for that patient, a blood pressure cuff that's disposable, one of those yellow plastic stethoscopes that you can't hear a thing out of, okay, the disposable gowns. Of course, gloves are disposable. As much of the stuff that can be done that can be used to terminally clean that room, okay? And then, okay, so when do you do surveillance cultures? Okay, so say you get unlucky and you get one on a specific unit of your hospital, and say it's the surgery unit, or so we have 3 units. We have oh God, and why aren't they gone? Okay, that's their 3 units: surgical, medical, and ICU. And so if you get them in a specific area that can be um, sequestered, you only have to do surveillance cultures on the individuals that were in that area taking care of that patient at that time. Now, in a small hospital, that's probably going to be every employee. Okay. Um, if you have multiple cases and they are spread throughout the hospital, you're going to have to surveillance culture everybody. Candida auris can actually survive on surfaces for several weeks, and that makes it unique amongst the yeasts. Yeasts usually don't like to live where it's not wet, and most hospitals have dry surfaces. Well, it depends on where the urine flow is, I guess. Okay, and then asymptomatic carrier state. Alrighty. Okay. So, any questions? So we'll do fungal questions first, and if we got time, we'll do just general ID questions. Yes. Yes. You hydrate them till they're floating in their eyeballs, and try not to cause them heart failure if you can. But yes, hydrating them, clearing that amphotericin through the liposomal and the lipid complex amphotericins. They are much less renal toxic than traditional, so picking one of those. And so yes, it can be done, and I've done it. Yes. Yes, ma'am.
Incidence of biologic and fungal infections, do those correlate with each other?
Yes, ma'am. Yes, ma'am. Yeah, it just, I think, oh, I saw this number the other day and I've done forgot it, that there's currently, it's approaching like almost 50 different biologic agents are in the pharmaceutical arsenal right now. And there was a huge outpourer of those during the early teens, 2000 teens, right? And so you saw fungal infections go right up with it. And so this happened around 2013. I wonder why. It's not the blame, it's a multifactorial cause, but it correlates quite well. Yes.
I was wondering about how afraid are you of black mold? I mean, our patients come in quite a bit. I found some in the corner, and I'm moving out, and versus something, and I'm just going to put some kills over it. What do you advise, and how far do you investigate when it's just in the house?
Okay. So when there's a really nice little ICD-10 code, it's contact or exposure to mold. Okay. And I order the laboratories on them, take a good history like we all do, and I see, do they fit any of these disseminated is it limited to pulmonary? Could they have disseminated infection? Are they at high risk? Are they immunocompromised? Look at the whole picture. And then at the very end of the conversation, I say, this is not the end of the world. You do not have to sell the wagon, the mule, and everything else. Okay. Go and get you a nice mold disinfectant from the dollar store. You go in there and you clean and try to figure out where that water's coming from. Okay, there's got to be some sort of water that is getting in there somehow. If you're afraid of your home, it's okay to move if you want to. Some patients are so anxious about that they've got to go, and I understand that. But practicality wise, I say, now don't freak out about this. We can do this together, okay, and walk them through it step by step. The other thing, I forgot to mention this. The other thing is patients will come in with these reports from these air duct cleaning companies, right? The number one bacteria, fungus on that is going to be Scedosporium, okay? The spaghetti meatballs. And they are just beside themselves. And I say, yes, you're exactly right. Every time um, that unit kicks on and there's some spores in there, it's going to flop them right out the vent. And you had them cleaned out. Good job. Good job. Some of these companies can be a little predatory. So just keep that in the back of your mind that if they don't find something, they'll find a way to find something. Okay, you get what I'm putting down? You picking up what I'm putting down? Okay, okay, all right. So I talk to them, take a good history, do the testing, tell them you're okay. You have no sign of fungal infections. All your testing is good. I'm so proud of you that you recognized it could be the air ducts in your system in your home. You got them cleaned, and it sounds like you used a reputable company, if I can say that or not. Okay?
Is this a blood test with, I mean, for their, I mean, it's kind of a balance between their peace of mind and overall cost. What would you recommend, for black mold people? Is there something that you would say, get this, and if it's negative, they're happy, and some of them more peaceful?
hmm The one test that I would get that is the most helpful is the beta D glucan fungitel, is its brand commercial name. That is the piece of the fungal cell wall in their bloodstream. You, if I could only order one test, I'd order that one. And if they're like, well, I read on the internet about aspergillus, say, okay, I'm going to get the aspergillus antigen from your blood. We'll see if there's a piece of aspergillus in your blood. And when it comes back okay, we'll be okay. And you can help them step down from the ledge.
Is that an antibody we might all have anyway that is just, you know what I mean, that some antibody tests are there completely independent and fairly common, and then you might paint yourself in a corner?
Good point. These are antigen tests, thank goodness. So they're not antibody tests. Now, there is a fungal antibody panel that you can see historically have they been in a place or been exposed to something. But the beta D glucan and the aspergillus antigen, they're antigen tests. So they're actually a piece of the cell, they're a piece of that fungus. And you won't have you won't have that problem of painting yourself into a corner, thank goodness. And what was the other thing I was going to say? It was brilliant, whatever it was. And it's gone. Okay. Yes, sir. It's mostly systemic, sir. And these are very sick individuals, usually hospitalized. Yes, yes. You get the rare, weird cases, like, of course, I had to be that guy, you know. Okay. Any general infectious disease question you wonder about I can help with? Yes. Okay. Yes, sir.
I also received one about like general syphilis on the rise in Tennessee. Can you speak to that?
Okay. All righty. So, congenital syphilis increase is, how do I say this politely? Tennessee is still very conservative, but we have a lot of people, yes, yes, we have a lot of folks moving into our state that their value system may be just a tad different. And that's okay, because it's one big tent where you can all live underneath it. And there's a whole lot of sex going on. Okay. Now, a lot of it is because of little to no prenatal care before delivery. So the screening that is done, they'll catch these. The OBGYNs are very good at catching syphilis before it ever becomes a problem. But it's these individuals that present with little to no prenatal care is where we're seeing the congenital syphilis at. And so that's, and these folks are, some of them are coming to our state, some of them are native residents and things like that.
What about the, like, when I get a patient
Yes, it is.
Is that something that is just the manufacturer or
Mm-mm.
nationwide?
No, it's okay. So, uh, a lot of you, and me included, used to give just plain old penicillin G shots in the office when someone come in with a strep throat, right? Then you went to replenish your supply and you saw the cost. And it was like, are you kidding me? So the health departments have quit carrying it because of cost, not because it's not needed, because of the cost, which is crap. Okay? Okay, so if they have insurance, you send it to a specialty pharmacy that deals in high dollar drugs, and you can get the little pack of 3 for latent syphilis. They get 3 shots, one right after the other, and that treats them for 6 weeks. That treats them for 6 weeks. And so it's a cost thing. It's not a shortage or anything of that nature. And that's the economics of it. It's pitiful, but that's the economics of it. When they don't have insurance, that's when I call the health department, which they also love hearing from me too. I call and guilt trip them and be like, now guys, you send me people and I see them for free, and I don't raise a stink, and I don't say, no, I can't see them because they're self-pays and things of that nature. I see them, and this person needs penicillin. I know you can order it. I know you don't have it on stock, and it's okay. They've had syphilis for Lord knows how long. They'll be fine for another week. You order it, please. Please order it and get it in here. So that sometimes helps. That sometimes works. Yes, sir. Yeah. That's right. Yes, that's right. 1 shot in each hip. And so at the HIV clinic there in Memphis, we would treat syphilis pretty much all the time. Okay. And if the nurses got tired and wanted to teach the patient a lesson, they'd take it right out of the refrigerator and pop them. And you'd see them walking down the hallway, and they're like, ow, ow, ow. Put it in some warm water, let it warm up. Be nice to the ones you love. If you want to teach someone a lesson, pop them. Yes. Thank you all so much.